Dr. Christian Perronne is Professor of Infectious and Tropical Diseases at the Faculty of Medicine, Paris, Île-de-France, University of Versailles, Saint-Quentin, France. He is Chief of the Department of Medicine at the Raymond Poincaré University Hospital in Garches, and is also President of the Communicable Diseases Commission at the High Council for Public Health. He is Vice President of the European Advisory Group of Experts on Immunization at the World Health Organization. He has co-authored and authored over 200 scientific publications. Ladies and gentlemen, please join me in welcoming Dr. Christian Perronne.
Thank you. I realized that I put front crash because I made a talk in Germany recently and I didn't change. Okay, I'm very glad to be here because now everywhere in Europe I think things are changing. Why I'm in the Lyme disease field? A long time ago, at the beginning of the 80s, I was an intern, and my senior registrar, Eric Dournon, was a pioneer of Lyme disease in France. He was a pioneer for many things. He said at that time that Legionnaire's disease existed in France. People at the Pasteur Institute, you're fool, it's on an American stuff. And same thing for Lyme disease. And he was the first to introduce serology in France and to diagnose patients. And I worked a lot with him at that time. He was a passionate guy. Unfortunately, he died young. And a few years later, when I was professor, it was in 1994, I was the chief of his department, and it's Versailles in the west suburb of Paris with big forests, and I discovered more about Lyme disease. So I discovered that I've learned disease in books, but in the real life it was different, and I remember patients. During 15 years, he has seen 80 doctors, 20 psychiatrists. He has lost his wife, has lost his job. He bought a house to build a marvelous family, and the house, he was not able to repair it. And in 1 month of intravenous antibiotics, his serology was negative, of course. And in 1 month of antibiotics, he was nearly completely cured. So I was so impressed by this case. And afterwards, I saw that many patients treated according to recommendations were cured. They were very happy. And they came back 1 month later or 2 months later saying, oh, your treatment was very good. But I'm experiencing a relapse. And often there are subjective symptoms, but you can find also objective symptoms. And I was embarrassed. I spoke with colleagues, trying to make it was a long time ago, a working group, but my colleagues said, no, this disease doesn't exist. They didn't want to play with me. So I was alone, and I discovered years later that some physicians in the US, some of the most important leaders are here, Dr. Rascano, Dr. Horowitz, took care of some French patients, and I've heard about them. And in a meeting in London maybe 5 years ago, I met Richard, and we spoke together, and I discovered that an ocean was between us, and we had exactly the same experience. So I was so amazed, and after I discovered in other countries, in Germany, in Belgium, in everywhere in the world, people have experiences, but it's impossible to go against the official version of the disease. Oh no, it's this one. So Lyme disease was described more than 30 years ago. In the northeastern part of the USA as a new regional event. Is it really new, really rare, really regional? And now we have many of the answers. Is it new? I think not, because Ötzi, the Iceman from Tyrol, aged more than 5,000 years, was found in the glacier in the Alps, in the Italian Alps. And this guy was lucky because for our patients we have no money to do good research, but but he had millions of euros to study his mummy. And they found that he harbored a huge amount of DNA of a bacteria very close to Borrelia burgdorferi. So now he's considered as the first case of Lyme disease. And my colleagues in France said there is no Lyme disease in Corsica because it's too south. And unfortunately, his genome study showed that he was probably Corsican. So I think it's not new. The problem is the pitfalls of the clinician, because I saw many colleagues when they see patients, they say, oh, you have not a tick bite memory, so it's not Lyme, go away. But in fact, even in the literature, it's shown now that many patients don't remember about tick bites. Sometimes it's an old thing, or the bite was not visible. And about erythema migrans is the same story, because it's not always present. When it is present, most of the physicians say, oh, it's just a little bit of eczema or insect bite, it's nothing. And as it was said today, sometimes you have very small EM, and so they are not treated. And in France, I think it's the same thing in other countries. Some inquiries among GPs show that most of them, a few years ago, they didn't know the name of the disease. Now they know the name, but when they think about it, they ask for a serology. It's not recommended at that stage. It's usually negative, so they say, oh, no treatment. And when they give a treatment, it's always a very short treatment, 5 days with very low dosages of antibiotics that are not efficient. So many patients develop secondary or tertiary disease. And if you make a biopsy of these erythema migrans, you see in histology a pattern of lymphoma, because somebody asked the question. I saw patients exactly like this with the same round circle on the belly. He was treated by a prestigious professor in Paris for lymphoma with several courses of chemotherapy because his serology was negative. He experienced a relapse 1 or 2 years later, and he was cured with doxycycline. But what I did with doxycycline was not recognized as evidence-based medicine, but to give several courses of chemotherapy was fully recognized because it was a histological proof. Not all patients have specific lesions as here for ACA, and as it was said this morning, this disease can mimic everything, from the hair to the toes, and including many autoimmune diseases. So it's very difficult, and I fully understand that my colleagues are completely confused about this disease, as they were before with syphilis. But probably the difference with syphilis, it was easier to treat. If we look a few years ago, at the time, because the French consensus conference took place the same year at the IDSA conference, I looked at the literature at that time, and you see that serology, it was shown this morning, it's between 20, sometimes 100%, but if you look at the series where you have 100% sensitivity, it's usually in rheumatologic studies, and I know my colleagues in rheumatology, in Paris at least, if you have not a positive official serology, you are not included in a cohort of Lyme disease patients. So all their patients, it's mandatory, has positive serology, so it's 100%. So, but after that, in the meta-analysis, it appears that some series have 100% sensitivity, but it's just a bias of recruitment. So you see that it's not optimal test. PCR, it was said, it's not optimal. Culture is sometimes difficult. So it's a big problem. So now, in routine for the poor physician, I'm a poor physician, diagnosis mainly relies on serology. But we'll see that it's a big problem with serology, with underdiagnosed patients, under-evaluated epidemiology. And if the patient has no positive serology in France and in most of the countries, he's declared non-ill person, And if he insists on, yes, I am ill, he's sent to psychiatry. So, and I remember 15 years ago, myself in my department, a woman with a psychotic syndrome, very severe. I was convinced because of her history that it could be vector-borne disease. And I decided to treat her with antibiotics. I had against me the family, the GP, several big professors of internal medicine in Paris, my colleagues in my department. And when I was out of my department a few days, she was sent to, or she was going to go to a psychiatric place to be like in jail. And the police was looking after her because she escaped. And I was alone against all these people, and I said I would not abandon this woman. And now she's cured, she's a director of a school. But I remember at that time, people wanted to send me in psychiatry. So people say you're doing foolish things. Look at evidence-based medicine. So I take my glasses, I look at the literature, and what I see, oh, it's very nice. The sensitivity of, it's not me who think that, it's the literature. It's between 20, sometimes nearly 100, but I told you why. But usually it's between 20 and 70% sensitivity. For any other disease, it would be a real problem. For Lyme, it's fantastic. I don't understand why, but it's like that. So we live under the Boston Law that was written by IDSA a long time ago. For ELISA, we should use the historical tick-derived strain B31 of Borrelia, burgdorferi, sensu stricto. You know now that there are many strains around the world. Though now in Europe, we are authorized to use Afzeliae and Gariniae sometimes, but not the other strains. And the two-tier test is mandatory, with the first step with ELISA, and positive confirmation by Western blot. But the problem is, officially, Western blot is not allowed in case of negative ELISA. And I know that some labs in the world, and including in France, have problems because or some physicians now, have problems because they ask for a Western blot with a negative ELISA. So I looked at the literature to see some reviews published in good journals, and people reassured me because they said, oh, the precision of test is impossible to measure in absence of a gold standard because the clinical signs are not specific, often non-reliable. Culture PCR are poorly sensitive. So how you can define the threshold of a test if you have nothing to compare to? So I looked at EUCALB, it's the European Concerted Action on Lyme Borreliosis. They follow the recommendations of IDSA. And I saw that it's written on their site that they calibrate their test by measuring the sensitivity on healthy blood donors because it's impossible to measure on patients because nobody knows who is a patient. That's a problem in this disease. And culture, PCR are not reliable, sensitive enough to have a big cohort with 100% of people with positive culture, positive PCR. So 30 years ago in Boston, they said, they had a good test, they invented a new serology, but where we put the threshold? Usually for HIV, now we have the culture, the PCR. For other disease, we can have a very specific score. They had nothing, so I don't criticize. Maybe I would have done the same thing 30 years ago. They decided to put an arbitrary threshold, and they decided that as it was considered at that time as a rare disease, a new emerging disease in northeast part of the US, it was decreed that there should be everywhere in the world, no more than 5% seropositive patients in the population. So this level of 5%, many people ask me, where did you find that? It's not published anymore on the sites of IDSA or EUCALB, but it was presented as a French consensus by Dr. Assus, working in France for EUCALB, and I saw it on the slide, and he wrote it, and it's published in Médecine et maladies infectieuses. It's written in French, but it's a PubMed reference journal. And he explains how UCAL recommends to all the European laboratories to do the test and to avoid more than 5% seropositive blood donors. So as it is decided by region, I understood afterwards why I saw some patients doing the same test of the same laboratory, but in Strasbourg or in Paris, another town, taking the train. And the day after, they could be positive in one town, negative in another. So the people in the official lab say, no, we have a very good sensitivity, it's higher than 90%. But if you look at the sites and IDSA, UCAL, they say, okay, we calibrate on healthy blood donors. Afterwards, we confirm the sensitivity on the test on real patients provided by real physicians knowing the disease. So they have a collection of sera, and they verify the sensitivity on this sera, but it's a collection of sera with very high level of antibodies. They're always positive. So they say our tests are very good. But it's evaluation is on tests in the lab. It's not in real population. So in 2014, some independent experts in France looked at the literature, looked at, it's not me, it's microbiologists, university microbiologists who did that, not involved in Lyme disease, wanted to understand what happened. And they look in the literature, they look in the manufacturer brochures and so on, and they could see that there was a great variability of the commercial tests marketed in France. They discovered that many tests used a few years ago don't exist anymore. New tests arrived on the market. And they discovered that now the manufacturers don't evaluate their tests on cohorts of controls of patients or positive. They just compare with the former test marketed, who was evaluated with bizarre methods years ago. So they said that there was no clear definition of the population of cases in control and great uncertainties on the predictive positive and negative values. And if we follow the recommendations of 90% specificity for ELISA and 95% for Western blot with the current methods of calibration, I'm not sure they are really good, but if we follow that, today the tests marketed in France, only 13 or 33 ELISA tests are considered as correct. The others could be sent to the dustbin. It's not me who's saying that. So confirmed cases of sero-negative Lyme disease are well established in the literature for 30 years. I remember when I was a young senior registrar a long time ago, we could see papers in the New England Journal or Lancet saying publishing cases where the serology was negative and the Borrelia was discovered by culture and after by PCR. And you have cases published in major medical journals. But if you speak with many so-called experts of Lyme disease, it doesn't exist. But it's written in many papers. And we saw such kind of patients. And even with serious, it was a randomized trial published in the New England Journal. And you can see that 40% of the patients included were seronegative for Lyme disease, but they were published in the New England Journal. I think it's not a minor journal. So why they were included? Because they had tick bite, erythema migrans, and association of symptoms belonging to different categories, articular problems, muscular problems, cardiac problems, and so on. So the investigators considered that they were probable Lyme disease, and in fact, they had the same results in the study than the others. It doesn't exist, but many patients were published in the New England Journal. So I was amazed when I saw the statistic I will show you just after in Europe. Lyme disease nearly doesn't exist on the British Isles because I had to prepare a talk I made in London a few years ago, so I looked at the numbers. and it was 0.8 for 100,000 inhabitants. So I said to myself, it's strange, why is the Borrelia on the continent? They don't know how to swim to the islands. But now avec the tunnel, I think the English should be afraid. And when I met some English colleagues in London, they said, oh, we see a lot of cases, but we are persecuted because all the tests are always negative, and we are doing malpractice every day. And I saw that there were publications from the Scottish colleagues. Somebody talked about this study. It was Dr. Shah, I think, this morning. When they use the same test recommended by the IDSA, but they replace the B31 American strain by the Scottish strains, the result was much better on the same sera, because I think the American strain isolated in Connecticut 30 years ago is not the good strain for all the world. So it's pragmatic, but it shows that probably there are many Lyme disease or Lyme-like diseases in England or Scotland, but they are not diagnosed because the tests are not adapted to this country. So if you look at the epidemiologic numbers a decade ago, that was a publication when there was a conference in 2006. In France, it was like TB, tuberculosis, around 9 per 100,000 inhabitants. Alsace, it's close to Germany much more. Germany, it was higher. Sweden, it was higher. I didn't have numbers about Norway, but probably it was close to Sweden. England, very few, and USA, it was like France. But now we observe that there is a high increase. I will show the numbers of incidents in Europe, and it's official. Despite the lack of improved diagnostic tests, because the tests today are the same. But I think that the physicians now think much more about it than 10 years ago. Because when I discuss with my patients, with my colleagues, GPs, most of them didn't know even the name of the disease 10 years ago in France. And when a patient came with a magazine, said, oh, look, there's an article about Lyme disease. Here is a red circle. I had that last year. I think I have Lyme disease. So the physician said, what, Lyme disease? I don't know. Or, oh, yes, it's a very rare disease in the US, but we have not that in France. But now I think they changed their mind. They have also ecological changes, and when I discuss with people and veterinarians working in the field, they say that much more wild animals in the forest, less hunters, more deers going on the lawns near the houses in some places. People go in the forest for many sport activities. So now we have official numbers published by the Institut Veille Sanitaire. It's a small French CDC. We have the numbers for 2011. I told you it was 9 for 100,000 a decade ago. Now we acknowledge 43. So, but some colleagues at the National Reference Center said it was written, I saw that on internet a few days ago, there is no increase of Lyme disease in France. I think I should buy some glasses for some people. So the incidence is not homogeneous. There are high incidence regions, Alsace near Germany and Meuse near Belgium, intermediate regions, and so as in other countries. So I looked in recent literature in neurosurveillance. It's a paper made by different investigators from different European countries. It's an official publication, and what I saw is really interesting. They say, took just a small words from the publication. Accurate description is impossible. Good. No plan to monitor at the European level. Fantastic. Non-standardized case criteria. Oh. Uncoordinated system of data collection. Wow. Clinically diagnosed cases, including erythema migrans, and they are not reported, okay. Criteria for serology not standardized. Oh, I didn't know that. And great heterogeneity. So that's what's published officially in Europe. But very... but there is no problem. So if we look at the data, the incidence range from 1 case per 100,000 to 350. I think the country is 1 case. I'm not sure of the data, but I will check one day. So you have some hotspots. I was in Germany recently. It's very dangerous. Here, there is no Norway, but southern Sweden, Estonian, Finnish islands, it's not far from here, the Baltic coastline, so maybe it's very dangerous here also. So, as you know, in August 2013, the CDC of Atlanta said that there was a 10-fold increase of incidence of Lyme disease now in the USA. Instead of 30,000 cases per year, now it's 3,000 cases per year. And it is acknowledged now that Lyme disease is a tremendous public health problem. So when we ask in France to the experts, they say, oh no, because it's 30,000 cases during 10 years. So if you multiply 30 by 10, it's 300. Look, it's the same. That was said to some journalists by some experts. And the same thing was said in, I think, as a Belgian television recently. There is no move. There was 30 per year, 300. They have a license of mathematics, and they said no. So why there is this increase? Because in 2011, the CDC of Atlanta revised their case definitions. I can't go through the details, but they say that the Western blot alone may be sufficient to report. There is a possibility to declare definite cases, but also probable cases with clinical criteria. So I say, why don't we change for the clinicians also the definitions for IDSA, UCARB, the French center everywhere, for the medical insurances, because they say a positive ELISA is still mandatory. And they answer to me that they have criteria for statistics. So you can be a patient for the computer, and there are criteria for the physicians. So it's the first time in my life I see a disease where the criteria, and you have 10 times more patients in one side than in the other. Imagine that for HIV. I don't understand. So, not for statistic only, because now with the old good method, we detect 10% of the patients detected by the new criteria. So for the poor clinician I am, there is diagnostic cul-de-sac, and a huge proportion of patients have no access to treatment, or at least to consideration. And I recently saw a young guy I met a few years ago. He was from Les Vosges, it's a region near the big forest near Alsace. He was very ill. He was considered by all the physicians to be a psychiatric guy. He had terrible pain everywhere. He was put in a psychiatric ward during several months. Physicians said to his parents that he was a psychiatric person condemned to stay in the hospital for his life. But now he's cured. After that, he could escape. He could be treated. Of course, his tests were negative. Otherwise, the story would not be so interesting. And I asked him, because now that he recovered, he's working full-time and loving life. I asked him, how did you have the courage not to commit suicide when you were in psychiatry? He told me, my disease saved me because I had so much pain. I was so tired. It was impossible for me to move and to get out of my bed. I wouldn't have the energy to take a rope to hang with. And I know that many patients who committed suicide. I don't know them directly, all of them, but I know that's a frequent problem. So how our colleagues accept or not the possibility to have sero-negative Lyme disease, even if it's published everywhere? That's very different according to the specialties. Many physicians are convinced that there are many more false positives than false negative patients. If you go in rheumatology, even you have pain in the knees and swelling, and you have a positive serology, you say, oh no, it's not Lyme, it's so rare, you have a rheumatoid arthritis, and so on. In rheumatology, you have never a case of Lyme disease with a negative serology. So we say you have fibromyalgia, sero-negative, rheumatoid arthritis. And what I think funny is a professor of rheumatology in Paris says to a patient, without any argument, oh, you have a negative sero-negative rheumatoid arthritis. All the physicians around say, oh, he's a very nice professor. He immediately saw the diagnosis without any clue. If I say, excuse me, maybe it could be a Lyme, sero-negative Lyme disease, they look at me, what he's saying, he's insane. And neurologists are more receptive to the idea of negative serology, but only for the acute severe cases. Otherwise, they could die. So in the European recommendations published by people from Strasbourg in neurology, it was acknowledged that as a, it's bizarre because the same people saying our serology is excellent, they acknowledge in the neurology article that sometimes there are seronegative patients and empirical antibiotic therapy could be given. But it's the only situation where it is written, not for the other conditions. And if you look in the literature about Lyme neuroborreliosis, you see that the intrathecal secretion is that depends according to the countries, the studies, but it's not optimal. And here there is a study in children in Sweden, not far from here, in 2008. If you look in the blood, only one child in 4 has positive antibodies. And if you do the spinal tap, nearly 3/4 became real patients, because before we were not patients, but after the spinal tap, they have a diagnosis. But you can see that if you don't do the spinal tap, they have no disease. That's surprising. So it's an important problem for the clinician because we have no good test to rely upon to how to objectivate abnormalities before giving the label psychosomatic. And we published that with Odile Roche-Langto in a French journal. It was written in English. About 30 patients who all their serologies were negative. They were considered as psychosomatic. But they had cognitive disorders. And if you really study by objective tests, they exist, this test, the cognitive disorders, MRI, evoke potentials. Often you can find lymphocytopenia, lumbar puncture. You find in most of them 1 or 2 objective abnormalities. And now we have publications in the literature about SPECT scan, brain blood flow study of biological markers. So if we really look at objective markers, we can find them, but it's not done in routine practice. So here are the tests made in my hospital. My hospital is dedicated to disabled patients. So we have orthophonists who are who do that in routine. I didn't do the test because I'm afraid to give the good answers, but it's very sensitive to measure abnormalities. And they found on the MRI some lesions resembling a little bit to multiple sclerosis, but sometimes changing in location and changing during time. And in Brazil, it's published in several papers. They found a Lyme-like disease with erythema migrans and all the symptomatology, but they couldn't find the bug. They saw it on the dark field microscope. Lyme serology is always negative, but they didn't succeed in culture. Here's a dark field microscope. So, as it was said this morning, there are now a huge amount of new species of Borrelia, sensu, lato, Lonsteri. Miyamoto seems to be a good candidate now because when I saw it the first time I spoke to French colleagues, oh, Miyamoto, no, it's a rare thing in Japan, it's not here. After that, it came in Russia, and then in North America. Now Holland is not far from France, but they keep on their shoes, and they said, no, it's not in France. And in February, it was published by a French veterinarian using high-throughput sequencing that Borrelia miyamotoi is present in French ticks in Alsace. But it's well known, French ticks never bite French people. Not a single case in France. So I spoke about the Brazilian spirochete. So you have other spirochete, but unfortunately, as good studies were not done, we don't know the correlation with the clinical pattern, and some were occasionally described. So, but many studies should be done to clarify all these bugs. Even Wormser acknowledges that there are other co-infections that are frequent, granulocytic anaplasmosis, babesiosis, and other tick-borne infections. And a new one, Candidatus Neoerlichia mycorrhizis. I think that Richard didn't see it in the US. I don't know if it's only in Europe. It was described in Switzerland, I think 2 years ago. It was a recent discovery in a person in Switzerland with high-grade fever, with a septicemic clinical pattern, and they could isolate this new bacterium in the blood. And now, when I was in Erfurt in Germany, unfortunately, I couldn't attend the meeting because there were 2 rooms. There was a special session about this new bacterium. It appears to be an emerging pathogen in Europe, but I don't know if it's already found in America. But now my hope is that new techniques are coming out, new generations of PCR, because it was told this morning, and I showed you the PCR were not very good in the past, and new techniques of high-throughput sequencing, pyrosequencing, and so on. Here there is a study published by our colleagues from Boston recently, it was in February or March, at the Milford Hospital. They use what they call a proper nested PCR. I don't know what is proper PCR, not proper, but it was better than before. And they say that with these primers, they could detect more spirochetes. So they worked with the CDC. The CDC sent more than 50 blind-coded sera from patients or controls, and they didn't say if they were treated, not treated. It was completely blinded. And they did the test. And on the 20 pre-treatment sera, they found 2 cases of Borrelia burgdorferi. That's not surprising, but one was sero-negative. That's not possible. It doesn't exist, but they found. And they found Borrelia miyamotoi in 1 case, just about 1 out of 20. It's funny because recently I submitted an article, I think I was reviewed by people from the USA. They said there was not a single case of miyamotoi in the US. And of the 12 post-treatment sera, isolation of novel Borrelia species was made. It is not named yet. And so burgdorferi, okay, miyamotoi, it seems present now in the States. And this novel Borrelia is also, like miyamotoi, close. It belongs to the family of the relapsing fever Borrelia. And it is surprising, it was isolated in the post-treatment serum of a patient with clinical neuroborreliosis. So it was a patient with meningitis or encephalitis resembling Lyme disease. He was treated, and they discovered this Borrelia in blood after the end of treatment. But as you know, Borrelia never persists after antibiotic treatments. Common epitopes were present with Borrelia burgdorferi, but they are not sure that it would cross-react, and they said, but about 1 strain, it's not possible to say. It could be more resistant to antibiotics, but we don't know. So now I think that veterinarians keep the lead because they have more funding than us to make new discoveries. And here Muriel Vessier-Tossa, she's a very clever veterinarian woman working at the Maison Alfort University. It's the biggest veterinarian school near Paris, using the high-throughput sequencing. I'm a little jealous because for ticks she has a lot of money, but for humans we have not. She collected ticks in Alsace, near Germany, and she found many bugs you can see here, including Miyamotoi, that doesn't exist in France. Candidatus Neoehrlichia microrensis. It was only in Switzerland with the chocolates, but now it came. Ehrlichia canis and different kinds of rickettsia. So all these bugs could be transmitted to humans, but to reassure you, there is no test for all these bugs for humans. So we can't evaluate that. So I think all these techniques are marvelous, but are very expensive. And I asked for fundings to test that several years ago, but it's always rejected. Why put money on a disease that doesn't exist? So funds are available for animals and for the mummy Ötzi, but not for patients. Other co-infection, it was spoken about, so I will pass on that, but it's also a problem. So now we live with the Boston, I call the Boston diktat from IDSA, the two-tier test is mandatory, and now we see that it's not possible to maintain this position with all the data going everywhere in evidence-based literature. I cannot understand in every other disease recommendations would change, and there nothing changed. I don't understand why. So if you look now, it's terrible. In 2014, on behalf of science, on behalf of universal knowledge, on behalf of liberty of thinking, the witch hunting is ongoing worldwide. And now it's very tough in France. Physicians are persecuted. Published evidence-based data are ignored in the recommendations. Labs are closed in France, but probably in other countries. I remember I had to help an English physician who was attacked 3 years ago. Publication in major peer-reviewed journals are not possible. I know that because I tried to publish in many journals. If you publish a little bit differently than the guidelines, it's anti-science. And research fundings are never granted. So I agree with the remark this morning that sometimes Lyme physicians do things that are not proven, but we want to prove, to evaluate what we are doing in good studies. It's impossible to have funding. So that's a vicious circle. It's terrible. So I was very upset before coming here because last month I was at the Belgium Senate at the demand of a Belgian senator, and just when I was going inside the plane to come here, I've heard that Valerie Obsommer, Belgium University veterinarian, a very nice woman, working on the correlation between tick infections and human cases with a huge amount of data, was fired a few days ago by the Université Catholique de Louvain in Belgium. Her fault to have said the truth at the Belgium Senate last month. Ticks are infected and human cases exist in Belgium. And the official version of many experts in Belgium says there is no Lyme disease, it's very rare, it's not a problem. Now I'm a little bit afraid because I sat beside Valerie at the desk of the Senate. Maybe I will be the next on the list. But I wanted you to think about her because I think that's not normal. In 2014, it's like the Inquisition. So I think enough is enough. So so I was so upset that last night in my room, I wrote a poem I want to read today, the Boston Tea Party. Hello, Mr. IDSA, Mr. No ID, Mr. No Assay. Do you see something? IDSA, I don't see anything. Is there a trick to deny the fear of ticks? Hello, Mr. IDSA, what do you say? You say any test needs 2 tiers. The eyes of patients are full of tears. You say anti-science is a single tier. Your guidelines, patients tier. Doctors ask for a Western blot. You say it is a plot. Hello, Mr. IDSA, what do you say? You say it's only psychosomatic. Antibiotics are not automatic. When life is destroyed by ticks, what is your concern about ethics? Bye-bye, Mr. IDSA, you won't have any more to say. The Boston Tea Party launched the American Revolution. The Boston Tea Party will launch the global Lyme revolution.
I'm very happy that also in Europe there are still scientists who think. Thank you very much for it.
Thank you.
If I look at your speech and especially your cynicism, did you ever consider the possibility that it's not a natural disease you're fighting, but it's actually been done on purpose and knowledge is kept away?
I have no data to say that. I know that there are some rumors, but I'm not a microbiologist. I don't know anything about the genetics of the strains, and I don't know.
Because to me it seems too structural, like tests are being kept away from you, knowledge is being kept away. And 60 years, which is how long it is in Europe next year, is a long time for a system to remain ignorant.
It's not possible for me to answer to that.
Thank you.
Over here.
I would like just to say something because I know Christian Perronne for about 10 years, but it was about 2 years that we met personally too. I know about all the effort that he has tried to do. I know also about all the effort that many other colleagues has done in this field. And I would like to thank you, Christian, for this presentation because it's like for the Dr. Horowitz. I think we have to have the courage. We have to say, just to say how things are, because the problem is, I think, there is no open-minded discussion with the two poles that we have. One side, people are telling one thing, the other side, people are telling the other, and there is a kind of exclusion, a kind of non-communication between these two poles. And I think this is what we have to change, and we should listen to each other. And I am sure that when they are seeing all what we are trying to say, they will understand it. And also again, the same way as before, that we have to do a lot of things. We should get together, the scientists like the patients, they are suffering, and we need money. Simply just to go ahead faster and to do such meetings that it is here today. Thank you so much.
Thank you. I think that we should approach the problem differently, not only with a small group of medical experts, but it will be much wider, international, with physicians, veterinarians, sociologists, epidemiologists, people from many fields, because it's not only the Borrelia, burgdorferi, sensu stricto, and that's a middle-age period, like serology. We should move on, and I think now all the publications coming out with new techniques, the fantastic work done by Dr. Shah with all the techniques, all the bugs she finds, we could change and with perfectly evidence-based data, change the description of all these diseases and go forward. I don't want any more of these sterile controversies about Lyme disease that are going on for 3 decades now. It's completely stupid. We spell energy in nothing, and we could work all together to move on. That's my ambition, and I think I thank Siv and her colleague to have created with other people, the Norwegian Society. In Germany, the Deutsche Borreliose Gesellschaft, they organized a marvelous meeting with very high-level scientists in Erfurt. In many countries now, we have clever people with good scientists. We should join and make an international European or transatlantic society with scientific goals to go forward. But I think now maybe if we are all together, the politicians could change and give some financial help to start, because unfortunately now the pharmaceutical industry, the people who make new reactives for labs, they were not motivated to work in this disease. If you are entrepreneur of a new startup as a company, you don't want to put your money in a field where everything is in the battle and you don't see the rapid return on investment. And it's so I think this field was abandoned during years and years, with poor clinicians on the field doing what they could do. And I feel if I continue my fight, it's for the patients, because it's terrible for them. And I'm the only university physician in France taking care of patients. I know 3 colleagues in other hospitals, but not university people. Now there are more and more GPs, but they are attacked. But the poor patients, they have to spend a lot of money to go to Germany, to go to see Richard in the US. It's terrible.
Okay.
Christian, one of the things that has made a big difference in the US is the increase in incidence, which was reported last year. It's definitely had an impact. I speak from the perspective of someone in the media. The media is more interested in covering Lyme disease since the new incidence figures were released. What can be done about looking at that in other European countries? In your view, you've mentioned that there are clinicians that know that they've had patients come to see them that they suspect might have, a disease like this. What can be done to improve the reporting of incidents?
An impulsion coming from some experts with the agreement of some authorities, it could go on. Because a lot of my colleagues say, okay, we think you're right, I agree with you. Sometimes I know that they treated secretly some patients, and they say, oh yes, it works, but after that they are afraid because when they treat too many patients, sometimes they see exacerbations or some relapses, so they are afraid to use not recommended treatments. And they say, we are ready to play with you if it's in an organized protocol with good experts on this lab side. People agree now. I think in their mind they are convinced there is something. But they don't want to, as said our colleague from Norway this morning, to see all the physicians doing prescriptions that are not recommended. I understand this position. It's a real problem for us, with also the problem of antibiotic resistance. It's not easy, but I would like that should be studied in good conditions with an official surveillance. But my colleagues would agree to participate in official studies on that.